So sorry, I have a few wires and things I need to get in place. I have a soft voice, so if at any point in time you find you can't hear me, please let me know, especially at the back. If you could wave, that would be wonderful. So as you know, the first part of our session today will certainly be discussing rehab for brain tumors, and this is an area of passion for me, so I'm so thrilled that I get to be able to share this really with all of you. But maybe before we get started, I do want to know who's in the room. So maybe if we could get a show of hands, patients, families, loved ones, caregivers. Wonderful. Wow, amazing. Any nurses, doctors? Great. Phenomenal. Researchers? Thanks. Allied health professionals? Good. Anyone specifically from rehab? Wonderful. So thank you. It's so nice to know that we have such a diverse group here today. Thank you so much for coming. Certainly over the next 20 or so minutes, we'll be discussing a few things, and really this is an overview of rehab in brain tumor care. We'll start out by talking about what rehab is. We'll discuss some of the rehab needs of people who are living with brain tumors. We'll certainly go on to discuss some benefits of rehabilitation, barriers in accessing rehab services, and then we'll certainly go on to discuss rehab approaches throughout the brain tumor trajectory, and we'll end off with some thoughts as to what maybe all of us can do in our community to help push for rehab services. So I just want you to all take maybe 2-3 moments to either write down or think about this question. What can you, your loved ones, or your patients need that hasn't been addressed? What's this gap? I think you have maybe some pens, some paper. Feel free to write this down, or just keep this in mind throughout our session. Okay, I'm seeing some heads up, pens down, so maybe we'll move forward. When I get the question of what rehab is, really at the core of rehab, it's helping people live better in the broadest sense. Other healthcare disciplines might be really focused on helping people live longer. At the core of rehab, we're trying to help people live better. And this isn't living better defined by me, living better defined by any other healthcare professional. This is living better defined by the person, maybe perhaps their family, their loved ones as well. And this is living better in the face of illness, in the face of impairment. And when I say impairment, these are things that impact on daily living. Things like changes in thinking skills, changes in the body, physical conditions, changes in emotions, behaviors, but even in speech and communication. The people who do this work are primarily occupational therapists, physiotherapists, speech-language pathologists, but certainly there are other wonderful allied health professionals, medical professionals, and researchers who really push this field forward. When we look at brain tumors and rehab needs, certainly there's no doubt that an immense amount of need exists. What the literature tells us is that people with brain tumors present in really complex and diverse ways. I'm sure this isn't a surprise to people in this room. One study in particular found that people who have brain tumors, 75% of people who have brain tumors present with 3 or more functional impairments that impact on daily life. 40% present with 5 or more functional impairments that impact on daily life. It's really important to know that there are these different constellations. And when speaking about functional impairments, these researchers classified the functional impairments in these ways, and the numbers that you're seeing up here are frequencies. Things like cognitive deficits, fatigue, weakness, visual issues, perceptual issues, sensory deficits. These are all things that can coexist. So certainly, with all of these functional impairments taken into account, it's no surprise that research shows that people with brain tumors have low quality of life. This is something replicated time and time again in the literature. When we look at one study in particular done by Edelstein and colleagues, she actually found that people with brain tumors report the greatest amount of distress, the greatest amount of illness intrusiveness, and lower positive affect than people living with any other cancer type. This is pretty significant. And certainly, when we look at the literature as a whole, when we look at what there is to be done about this, everyone seems to be pointing at the same thing. When we're trying to promote quality of life, the literature really pushes for people to help individuals with brain tumors engage in valued activities, engage in valued life roles. And hopefully this sounds familiar, because this is the very definition of rehab, helping people live better, helping people promote their quality of life. When we ask patients and family members about what their highest unmet supportive care needs are, so many of these things are related to rehab. And I guess I wonder, when I asked this question to you earlier, how many of you thought about things that were on these lists? I'd be surprised if you didn't. Certainly, when researchers have talked to patients, caregivers, things like physical effects, changes in thinking ability, feeling as though you're not the same person as you were before, re-engaging in work, promoting independence, and even accessing rehab services, are things that people are saying that they need that are largely going unmet. This is something really important for us to consider. When we talk about rehab efficacy, there have been a lot of studies that look at rehab in inpatient contexts, outpatient contexts, and at home. And largely what this research shows us is functional gains are possible, improvements are made. And what's even more exciting is a lot of these studies have shown that these improvements are maintained after discharge, after people leave these programs. And what I actually find the most encouraging as someone who works within the rehab system is that people with brain tumors who participate in rehab achieve similar functional gains to populations that we see in rehab all the time, people with strokes or traumatic brain injuries. So sometimes people hear the argument that people with brain tumors might not benefit as much as maybe people who have had a stroke from rehab services. And rehab certainly has been found to be equal in both cases. That's something really important to know. Occasionally, I get the question of if rehab can promote survival. And certainly, sorry, my microphones are getting away from me. But it certainly is the case where when we look at the question, can rehab actually promote survival, help people live longer, not just help them live better, but live longer? I have to say that the literature isn't quite there yet. Research isn't quite there yet, but some really interesting findings have emerged. These are largely associations. Research in this area has not been fully fleshed out, but certainly when we look at interesting findings, Rudin and colleagues found that exercise behavior alone is a predictor of survival. So when they looked at people who were exercising more, they found that individuals with grade 3, grade 4 brain tumors who were exercising more lived 68% longer than people with similar brain tumors who were more sedentary. Another study actually found that functional improvement over people's rehab stays were linked to people living longer, and this was specifically for people who had glioblastomas. So even though the literature linking survival and rehabilitation is incredibly early, incredibly young, and these are merely relationships at this point, I really do think that this is a fruitful avenue for further research. So we've talked a little bit thus far about rehab needs. We've talked about the efficacy of rehab. We've talked even about some early studies about rehab and survival, but certainly not everyone's rehab needs are addressed. We know this. There are inherent barriers that I think really everyone in this room has an important role to play in trying to minimize. When we survey the literature about barriers, 3 core barriers come about. The first is in relation to knowledge. Knowledge of patients, families, but also knowledge of healthcare professionals. There's a sincere lack of knowledge about the rehab role for this population and services, programs, and supports that are out there. The second core barrier is really related to services and systems. Certainly, care pathways are not linear. There's an inherent complexity here. So our pathways aren't linear, nor are they transparent, nor are they easy to navigate. Even for many healthcare professionals who work within the system, this is difficult. Additionally, particularly in some geographical areas, resources are incredibly scarce. Rehab services are few and far between. And lastly, when we're talking about services and systems, certainly there isn't maximal communication or optimal communication between treatment teams. And when you consider that maybe in someone's care, there's a medical team, a rehab team, a home team, potentially a palliative care team, if those teams aren't speaking to one another in a timely manner, care planning isn't optimal. And because of that, there are some inherent barriers. Lastly, there are a lot of barriers related to complexity, and this is a theme that we've brought up a few times today. Complexity of the population, but also complexity related to timing. We know everyone with a brain tumor is different. Their brain tumors affect them differently. There are different functional issues that present, and these aren't just static. We know that our patients or our needs or our loved ones' needs can change over time. So that in itself is incredibly complex. Speaking to that a little bit more, since we know that people's needs change over time, what I like to really advocate for is the right rehab approach at the right time. And I often like to debunk the myth that rehab has a very narrow focus in restoring function. Rehab has a pretty wide blanket, a wide umbrella when we talk about rehab approaches and services. And they can really take on 4 main approaches. The first is related to prevention. When we're speaking about prevention, one of the, I think, most concrete examples that I could bring up is strengthening before there's any kind of physical impairment present. Maybe strengthening when someone knows that they're about to undergo another round of treatment, doing things in advance of any impairment. When we look at remediation, this is trying to enhance people's abilities. So potentially for someone who has hemiparesis, one-sided weakness, this would be working with these individuals to promote function in their arm and their affected leg. When we look at the rehab approach of compensation, this is doing the same activities, making sure people are participating in the same activities, but in a different way. A good example of this is walking. For many people, they can continue to walk independently, safely, but maybe they might need a cane or a walker to do so. Maybe someone can continue to bathe and care for themselves, but they need a shower chair and grab bars to do so. When we look at assistance, rehab has a really important role to play here in that rehab professionals can help in determining an optimal level of assistance, provide education, and assemble resources as well. So an example here is maybe when a person gets to the point where they can't do stairs on their own, helping to teach family members or caregivers how to help their loved one up and down the stairs safely or in and out of bed. This could also be providing referrals to home care for a personal support worker to come in to help out with self-care activities like dressing and bathing. So certainly the role of rehab is quite wide. And what we need to do as healthcare professionals is know the services out there so that we could help give our patients the right rehab services at the right time. So we've discussed some barriers, and certainly that's with the eye for all of us to try and break these down. And I'm sure I don't have a comprehensive list as to what we can all do, but at least these are some first steps. These slides will be posted later, and I really encourage you to look back and see what's realistic for you to do. And these are just some suggestions today. When we look at the knowledge barriers that we were discussing, patients, loved ones, caregivers, certainly make your goals known. Discuss with people what can be done, who they can speak with about rehab. For healthcare professionals, know what resources exist in your workplace, in your communities. Take the time to do that. Facilitate referrals, or even provide patients and their loved ones with this information. When we look at services and system level barriers, patients and your loved ones, certainly get to know your healthcare teams. We know that there can be many, and they don't always talk to each other. So encourage them to connect. And on the healthcare provider side, be open to this and willing to communicate, because maybe something that you know is crucial for another team's planning. Additionally, in places where there aren't adequate services, when there are significant gaps in care and service delivery, all of us in this room have a really important job to play when it comes to advocacy. Advocating for programs and services where we know that they're needed, but also if we see that there are programs and services in our community with very strict referral criteria that people with brain tumors don't meet, we need to play our part in providing education and trying to advocate to broaden this criteria. And lastly, barriers related to complexity. Certainly, patients, loved ones, be aware that everyone's circumstances are different and they might change over time. So maybe what's right for you in terms of services and programs at one time point might not be what's right for you later on down the line. So ask for rehab, ask for services, and if your situation changes, please ask again. Healthcare professionals, certainly consider timing of rehab referrals in relation to ongoing treatment and your patient's changing functional needs. Certainly what this might mean for you is multiple referrals at different stages of people's trajectories. So I want to circle back to where we began a little bit. I want you to think back to the need that you identified, and maybe now with a broader understanding, just asking yourself this question: if rehab can help you, your loved one, or even your patients with the need that you've identified, and I really want to challenge you. What are you going to do about that? So thank you so much. I really appreciate it.